Hello, my name is Larry Radcliffe. I'm a family physician in Dayton, Ohio, and I'm also the medical director of Providence Medical Group, which is a large independent group of physicians here in Dayton, Ohio. I want to talk to you a little bit today about CPCi, patient-centered medical home, and the transformation of primary care. And so this transformation of practice is how we handle chronic care patients, how we handle acute care patients, what's the best process to see those people, and just how we take care of those patients outside of our offices, and that's a very important part. We do have 24/7 access to ourselves. We have a patient care portal so that patients or their family members can sign on, they can ask questions, and I'll respond to them, or a nurse will respond to them. If a patient looks at me as just somebody that is giving them an antibiotic for an acute bronchitis and they're out the door, then I'm not going to be able to affect the change that is needed to help bring down costs in healthcare and provide better quality. We also have patient education on there. We also will push diagnoses, medication lists, so if they get questions about that, patient histories, medical history, social history, family history. Patients are great about doing those things, and they do that online. And then it comes back to me, and before it gets put in the chart, I review it, but it's almost getting to the point of a patient-physician medical record. The more we get engagement of the patients, the better off we are. We can affect change. We can affect a new way of practice. We can affect this practice transformation. Our old practice model was based on seeing patients and for that one distinct period of time and getting them out of the office and doing as much for them that we could in a 10 or 15 minute window. With practice transformation, we're actually reaching out to that patient through our care coordinators, trying to get more involved in their care outside the hospital or outside the office visit. Our care coordinators allow us to connect with community resources, home resources, and insurance company resources, and coordinate that so that if a patient is a diabetes patient, they may be calling them once a week to get their sugar levels, what they've been testing at, and with my input, making changes with that, with their insulin dose or their medicines, whatever. And that care coordinator has made a huge impact on our practice. And I can tell you from my personal experience working with a care coordinator, I don't want to go back to the old way I practice. That care coordinator helps me in so many ways to deliver higher quality and better care. And before the advent of the CPCi program, I didn't have the wherewithal, the funds, or the knowledge base to go out and hire a care coordinator. CPCi has really allowed me to do that. And I don't know how I'd go back now without having that care coordinator in place. Care coordination, what this process is about is getting better hospital record access. We get a thing called ADTs, which are alerts from the hospital, from the ER, from when they're admitting patients, when they're transferring patients, or when those patients have been seen in the ER. And we're not getting that a month later like we used to, or even a week or two later. We're getting that thanks to HealthBridge in the community, which is an HIE, is putting that in front of us the same day. Our care coordinators are going through those lists and acting on that. They are being able to call the patient within 24, 72 hours, getting them back into the office to be seen, and either discussing with them directly or myself discussing with them about better ways to take care of them, what could have kept them out of the hospital, and making sure our medication and our care plan is the same. And as a result of that, they actually, we may even change some of those medicines. We may change that care plan a little bit, tweak it, or it may be that we go in a different direction. I've been asked before about, is this new patient-centered medical home CPCi project just more of the old gatekeeper process that we had in the past, where the primary care doctors were the keeper of the funds, so to speak? And I lived through that. and it was horrible. And the reason is there was no quality indicators to help drive that. There was no care expectations on what the level of quality care means. I think we've got a better idea on what quality care means these days. I can remember back in the capitation days that there were primary care doctors that made a lot of money off that, but pap smears weren't being done, mammograms weren't being done. There was a lot of negative kind of connotations for that. This program really holds our feet to the fire, and it also introduces, especially in smaller practices that might not have an RN in their practice, a registered nurse, it brings that registered nurse in who is the care coordinator. It gives us another person to bounce ideas on. There's audits that are going on. Those weren't done with the first program. There's very specific criteria. Those weren't done with the gatekeeper model. So there was a lot of talk about collaboration, involvement of specialists. This is driven off of quality care, and money is second. We all know that the healthcare crisis that's facing our nation right now, it has to do with runaway costs, and it also has to do with the new ideas and the new research and new procedures that are coming out. All the research has brought forth a wealth of new ideas about the best care. So where does a primary care physician fit in that whole thing? And it's part of the CPCi product. It has to do with engaging a primary care doctor that can get you through those areas. I have patients every day that brings in a program that is touted to be the best thing for low back pain. If it's something I've heard of, I can respond to it immediately. But if it's not something I've heard of, I'm comfortable enough with my patients and saying, I really don't know an awful lot about that. Let's look that up and say, here's what the real experts are saying about this. And it turns out, if you look at the data, that it's only meant for that 1/10 of 1%. And that part of it is so important for us to understand. If that decision has to be made, it's being made now and previously between the family, maybe some online resources, the patient, and the specialist that's telling them to do this procedure. You introduce a primary care doctor into that mix, and I can guarantee you that the outcome will be more thoughtful and based on data and evidence rather than just on what you read off the internet or what somebody's telling you. The other thing that's been brought into the CPCi practice and transformation of care is evidence-based medicine and shared decision-making. I can remember 10 years ago, 5 years ago, before this practice started, men got a PSA automatically. That was just part of the annual screening, and that was actually recommended at that time. PSA is a screening test for prostate cancer. With time, we've gotten new evidence that shows that that may not be the best way to practice, and we now share that with our patients before they get a PSA test. And we talk with them before they get a PSA test, and we say, here are the risks, here's our way of managing this, here are the things that we do. I want your input on this rather than just ordering them. If that patient looks at me in my practice as a resource for care, as a partner in care who's going to try to, if they've got a specialty need, trying to get them to the right physician, to the right place, that relationship is essential towards changing things, and they're more likely to take my advice.